channel. I'm Dr. Sara Ahmed. I'm an internist and a hospitalist. And today I'm coming to talk to you about the renal system. And for you to be able to understand what the kidney does and how it does it, you really need to understand about a very important microstructure that's considered a functional unit of the kidney, which is the nephron. The nephron is the basic unit that does the kidney function. And in each kidney, we have about 500 to 800,000 of these units or these nephrons. And collectively, they constitute the kidney or renal function. This circular or globular structure, which is called the renal corpuscle, and a tubular structure that's connected to that corpuscle. So the renal corpuscle and the renal tubules, together they form the nephron. But it's not that simple. Each of these has subdivisions and sub-subdivisions, and each is essential and very important in collectively performing the kidney function. Okay, first of all, let's clarify or agree upon why understanding nephron function is critical. And as I said, nephron function meaning kidney function, because the kidney is actually the container of these nephrons, and they are the ones who are actually doing the job. I usually tell my students that consider each nephron as a unit in a factory. And this factory is producing, let's say, clothes or some form of textile or some clothing item, pants, for example. And the output of this factory depends on the number of functioning units. If you have more sewing machines, you will have more product. The sewing machine being the functional unit. So if each sewing machine, that's the one unit, is producing 2 pants per day, then the collective function of the whole factory depends on the number of these machines that's actually functional and working. And this concept will become very important when we come to talk about chronic kidney diseases. Because chronic kidney diseases, basically, they are considered or called chronic because there is some loss of function to them and there is some impact on the number of functioning and healthy nephrons. It drops, gradually dropping. So you lose functional units as you go through the journey of chronic kidney disease. Understanding what the kidney does depends on understanding the nephron. Okay? And interpreting laboratory values depends on understanding what the nephron does. Managing fluids and electrolytes when you are clinically managing or therapeutically addressing issues with hyperkalemia, hyponatremia, hypercalcemia, whatever you are doing to these electrolytes on dealing with these electrolyte disorders, you are actually dealing with what the nephron does. A lot of medications target what the nephron does, like diuretics of the different forms, okay, antihypertensive medications, or a lot of medications are actually excreted through these nephrons and these functional units. So it's essential to understand how is it structured and how it does its job. Let's start by looking at the renal system as a whole. First of all, just to get this out of the way, when I say system, I'm actually talking about a number of organs and structures working together towards performing a function. In this case, the renal system has 2 functions. One function is, and it's the main one that's known about it, is the excretory function. The renal system is involved with excretion, excreting waste products, and in the process, it does a lot of other things. It concentrates urine, it regulates electrolytes, and it actually also has a hormonal function. So this system, it does excretory function, okay? So this is the function or the name system. So when I say system, I'm talking about a couple of organs and structures working together to perform a function. Going back to the renal system, it consists of these 2 kidneys. And by the way, these are located in the back. They are attached to the back of the body. They are retroperitoneal organs. And as you can see, these are bean-shaped structures. There are a pair, it's a pair of them, they are a pair or two of them. And this bean structure has this area, which we call it hilum. And the hilum is actually the region through which major vessels and other structures come in and out of the kidney. And out of this, of each kidney comes out a ureter to go to the urinary bladder. And this is important if you looked at complications that might develop as a result of pathology in one of these organs, and the formation of fistulae, the extension of infection, the extension of different pathological processes. Knowing that this piece of anatomy is important. This is the nephron. This is one nephron, consists of this part, which we call it the renal, we call corpuscle, and a tubular part, this long tube that comes out until it joins this collecting duct. We call it the renal tubule. The renal corpuscle consists of two structures. This tuft of capillaries, which is flanked between two arteries, we call it the glomerulus, and surrounded by a blind structure called the Bowman's capsule. And this Bowman's capsule actually extend to form the proximal tubule. This is the proximal convoluted tubule that comes to continue as that descending loop of Henle. And this is the loop of Henle. This structure, U-shaped structure, is the loop of Henle. This is the descending limb, and this is the ascending limb. Okay, and we are following the filtrate actually in this naming nomenclature. This is the ascending limb, and the ascending limb joins the distal convoluted tubule. This particular nephron is not anatomically accurate because this convoluted part, the distal convoluted tubule, actually goes to be closer to this area, and this will be important in a minute, but just this is kind of extended out for you to see how the flow of filtrate goes. Okay, and this is the collecting duct, and this structure was taken out of this area. It's a microstructure, you can't really see it, but this is for demonstration purposes. Now, this is more accurate, anatomically accurate, and it's giving me the corpuscle here, this renal corpuscle, which consists, as I said, of this tuft of capillaries. Look at this one here. The glomerulus is a tuft of capillaries that's very specialized and not found in any other part of the body aside from the kidneys and in the nephron. These capillaries are special because they exist between two arteries, okay? And in a minute I will explain why this is important. And this glomerulus is encapsulated within the Bowman's capsule, and as I said, Bowman's capsule continue to form the proximal convoluted tubule. Now, I want to bring you to this area. This part of the structure of the nephron is very important to understand. I want you to look at this here. This is a capillary bed, and this is a regular capillary bed connecting an arteriole with a venule. And this is found throughout the body. This is how these capillary beds are formed normally, traditionally. This is the arterial end, and the arteriole brings the blood, which is oxygenated blood full of nutrients, good for the tissues. So it brings it in and it spreads out among these capillaries, which are very permeable, and it allows the escape of some of the blood components, the liquid components generally, with its contained nutrients into the interstitial fluid. Okay, so this happens because we have two opposing pressures. One of the pressures is called hydrostatic pressure. And what the hydrostatic pressure does is it pushes the intravascular component, or the intravascular component into or out of the capillaries. Capillaries are very permeable, as we said. We are not dealing with well-structured vessels anymore. We are dealing with structures that allow escape of fluid in and out. So depending on the pressure in this area of the capillary bed, fluids are pushed out to circulate or roam in between cells and in the interstitial space. And in this time, they exchange nutrients and oxygen and everything with the surrounding interstitial fluid, which is in contact with the cells. And then This pressure as we go will drop. This hydrostatic pressure, this pushing pressure is going to drop until it reaches a level where it's less than the fluid that the pressure that tends to keep things within the vascular system. And this one is called the oncotic pressure. Oncotic pressure is exerted through some molecules in the blood, mostly proteins like albumin, for example. So the oncotic pressure increases and the hydrostatic pressure drops as fluid is moving towards the venule. And as you can see here, it's represented as constant. Oncotic pressure is constant. In this area, hydrostatic pressure is higher, that's why things go out. And in this area, lesser, the hydrostatic pressure is lesser, so the oncotic pressure is higher, so things will return back to the circulation. And it increases gradually, collecting all this fluid that escaped the vascular system to back into the venule, and the venule joins other venules to form bigger and bigger veins, and that's how they return to the circulation. So there is a limited amount of escape of fluid out of this kind of capillary bed, the traditional one. Now let's compare this with the glomerular capillary bed, the glomerulus, which is the tuft that's contained between two arteries. Remember that, two arteries. This glomerulus is flanked between two arteries, afferent coming and efferent leaving. In between, there is this tuft. It has the same transparency or permeability. It's very permeable, just like the traditional capillary bed. But here, the hydrostatic pressure remains elevated, okay? And it's never overcome by the oncotic pressure. Oncotic pressure is negligible. It's not really effective. So that whatever fluid escapes, and it will be escaping under high pressure because you have two arterioles here. Two high pressure systems, two high pressure vessels, not an artery and a venule like here. No, it's two arteries. So the amount of fluid that escapes out of this glomerulus is tremendous. It's very high, okay? And it's taken to go through taken into the Bowman's capsule, and from the Bowman's capsule, it's taken into the tubular system. This is a very basic and very important piece of knowledge that people need to know, okay? Now, I would like you to understand another concept that's very important in terms of the filtration process. Besides the pressure effect that's exerted by the two flanking arterioles flanking the glomerulus, we have what we call the glomerular filtration barrier. This is the layers that separate the fluid or the blood from the Bowman's space, basically. Okay? Blood and Bowman's space. This is Bowman's space where the components of the blood can actually escape from the intravascular area into this space and become filtrate and go into the tubular system of the nephron. Okay, this barrier consists of a number of layers. One is this fenestrated endothelium, this endothelial layer that's actually lining the arterioles. This has the ability to hold back some of the blood components that we don't want to escape into the filtrate. We want to keep within the vascular system. And this includes the blood cells. We don't want the blood cells to enter the filtrate. Okay, remember when we see blood cells in the filtrate or in the urine, this is indicative of pathology. So it's not normal. So the ferrous layer, the endothelium, keeps these blood cells and whatever they are, platelets, WBCs, RBCs, all of them are kept back because of this endothelium. It allows the whole plasma and the small proteins to escape. So blood cells and large proteins, they are not able to pass this endothelial layer. Then you come to another layer, which is called the plasma or the basement membrane. This is the basement membrane here, okay? And this basement membrane is able to keep or block any proteins that are above 70 kilodaltons in diameter. So any proteins bigger than 70 kilodaltons are kept back because of this basement membrane. The ones that are exactly at 70, which is the size of the albumin, Albumin is very important in kidney disease, so I want you to remember this fact. Albumin is not allowed to escape into the filtrate because of two things. Because of its size is at the borderline where things are stopped or blocked from passing, and because of its charge, it's negatively charged, and negatively charged molecules are unable to pass because of this negative charge in the basement membrane. So this basement membrane allows small solutes, ions that are positively charged, the water, all this to escape. Now we come to the third layer, which is mesangial cells, which we call them podocytes. And they have these finger-like projections or foot-like processes. And these podocytes actually are important to know because they are associated with some pathologies later on when you talk about glomerular diseases or glomerulopathies or glomerulonephritides. These are the components which are attacked by immune process or non-immune processes. One of them is these podocytes, and they are involved mainly in a disease called minimal change disease. Disease can affect children and adults as well. So these podocytes are the third layer, and they still allow some substances to pass, the water, the electrolytes, the small molecules, and so on, but they prevent any remaining proteins or albumin from crossing. So remember, the first layer, the endothelium, will not allow the big things to pass. The blood cells, the big proteins, they are not passing. Then it comes the basement membrane. Anything that's bigger than 70 kilodaltons cannot pass, and then the negatively charged molecules are unable to pass as well. The third layer, these podocytes, and these podocytes actually prevent the remainder of the proteins and albumin from passing, but it allows water and the smaller molecules to cross through. And whatever crosses through is actually the filtrate. This is very important. I would like people to understand this as well. So now, not to spend a lot of time, just I want to highlight the fact that this is a special kind of structure, not found in any other organ system or tissue, the glomerulus, and it does its function based on the same Stirling forces that are governing other capillary bed systems, but because it's flanked between two arterioles, the idea here is different because we want the fluids that are actually pushed out as a result of the high hydrostatic pressure to remain out and to go into the tubular system of the nephron. So these are the, now, just to recap and to be more organized, the gross anatomy of the kidney. The kidney is located retroperitoneally, okay? And it's the size is about 12 centimeters in length. Just compare it with your fist. It's the size of your fist, usually. It's bean shaped. The hilum is the indentation where vessels and ureter enter and exit. The blood supply is through the renal arteries, which come directly out of the aorta to enter the kidneys, each kidney. Then the internal structure, the interstitium of the kidney is actually arranged into the cortex, which is the outer region. And by the way, the glomeruli, all of them lie in the cortical area. The glomerulus or the renal corpuscles, all of them lie into the cortical area and part of the convoluted tubules, the proximal and the distal. The medulla, which is the inner region, this is this one. This is the medulla. They are arranged in the pyramid-shaped structures like this. So they are not just sheets of layers, sheets of tissue. No, they are arranged into these pyramidal structures. We call them medullary pyramids. And they contain the rest of the tubular structures of the nephron, which are mostly the loops of Henle. Calyces, these are minor and major calyces, and the callus is actually the renal collecting system. As they coalesce with each other, they form these minor calyces which join together to form major calyces, and eventually they form the renal pelvis, which is the beginning of the ureter. Let's just look at the nephron one more time. As I said, the renal corpuscle with Bowman's capsule and the glomerulus lie within the outer layer, which is the cortex, and part of the convoluted tubules, proximal and distal, lie close to it. The straight part and the loop of Henle goes down to go into the medulla. You see, it goes into the medulla. The medullary part of the nephron is usually the loop of Henle, and the length of which is different. We have sometimes very long limbs for the loop of Henle, and they extend deep into the medulla. And these types of nephrons actually play a role in concentrating urine. These juxtamedullary nephrons, which are the longer loops of Henle, are the ones that are used or mainly function to concentrate urine, and they constitute about 15% of the total number of nephrons, and the rest 85% are all mostly cortical nephrons, which are short loops of Henle, and they do the filtration and the other essential functions of the nephron. Okay. So the statistics, we have around 500 to 800,000 nephrons per kidney. Some authorities say it's 1 million nephrons per kidney, but I think that's an exaggeration. The structure, as we said, glomerulus, this is the tuft of capillaries for filtration. The Bowman's capsule, this surrounds the glomerulus, and it collects the filtrate. And after it's collected, it goes into the proximal tubule. This is a major site for reabsorption. Remember, some essential elements that should not be lost in the blood, in the urine, actually are filtrated into this proximal convoluted tubule. And the function of this proximal convoluted tubule is mainly to reabsorb these essential elements. Then the loop of Henle. Loop of Henle actually is the part that's concerned with concentrating urine through what we call current and counter-current mechanisms. And these are a little bit beyond the scope of this video, but the basic thing is they maintain the interstitial area around, or the environment around this the loop of Henle and the collecting ducts, which has some function with concentrating urine and preserving some of the electrolytes, potassium chloride, sodium and hydrogen movement across their walls. The environment that allows the permeability of water and the passage of water in and out of these collecting ducts and the parts of this ascending limb of loop of Henle is created by this loop of Henle. It's created by these the counter-current mechanisms employed by this part of the tubule. The distal tubule is mainly to regulate electrolyte balance. This is where the fine-tuning of the filtrate happens. The body will look around and see, what else do I need to get back into the blood, and what else do I need to lose or dump into the urine. The fine-tuning of this happens in the distal convoluted tubules. Collecting ducts, the final water reabsorption, as I said, urinary concentration, and the ability to do that, and it happens under the influence of the ADH. These collecting ducts are sensitive to antidiuretic hormone. It increases the permeability of the walls of the collecting ducts, and water can escape from inside to the interstitium here, and it escapes under osmotic pressures. And this environment, as I said, is maintained by the loops of Henle. This high solute concentration environment. The longer the loop of Henle, the more capable of producing such an environment and more capable of participating in urinary concentration. So these are the two types of nephrons, as I mentioned. The juxtamedullary, which are the heads of everybody, is here in the cortex. This is the cortical area. This is just a cartoonish structure showing that this is the head of one of the nephrons, and the limbs extend deep into the medulla. This is the juxtamedullary nephron, which is 15% of the total count of nephrons. This is the cortical nephron. I wasn't able to show the head, but it's a head like this one, laying within the cortex, and it extends that much only into the medulla. Okay. Now, what happens? You need to remember, if you would like to know the kidney and understand it, remember there are 4 structural elements that you need to know about. These are vascular, interstitial, tubular, and glomerular. Any of the diseases involving the kidneys involve one of these four elements: vascular, interstitial, glomerular, and tubular. And within the tubules, we have four types of functions or processes that can take place, or mechanisms. One is filtration, and we know who is responsible for that. It's the glomerulus. Okay. Reabsorption, mostly in the proximal convoluted tubule, but it actually happens throughout the tubular structures. Secretion, this happens later into the distal convoluted tubule. Urinary concentration, and this happens mostly in the collecting ducts and the distal convoluted tubules. Now, in the proximal convoluted tubules, 70% of the reabsorption takes place, and they're mostly sodium through the sodium-potassium ATPase and the sodium-hydrogen exchanger. All these are active forms of reabsorption. Glucose through SGLT2 and GLUT transporters. Glucose is a very important molecule to conserve and return back to the circulation, so it's reabsorbed here. Amino acids, again, these are smaller, of course, than their parent molecules, proteins, and so on. So they have to come back into the circulation. They need to be reabsorbed. Bicarb, another very important solute that needs to come back. This is the main buffer, okay? And what we use here for the bicarb to come back into the circulation is the carbonic anhydrase system, okay? And that's how the inhibitors of carbonic anhydrase actually work into the proximal convoluted tubule, and we have a set of diuretics that actually function here. This is a set of diuretics, carbonic anhydrase inhibitors, okay, in the proximal convoluted tubule, and it actually works by blocking this carbonic anhydrase system. That's why one of the characteristics of this diuretic is that it causes metabolic acidosis. Okay, and of course, water moves with the solutes. So the reabsorption of water is actually, it happens throughout the tubule mostly. And then we go to the loop of Henle, and the function of the loop of Henle is urine concentration. That's what it does. The descending limb, it's water permeable and solute impermeable. So here, fluids or water escapes out, but solutes stay in. The ascending limb is the reverse, water impermeable, but it continues to do sodium potassium chloride reabsorption. The movement of sodium, potassium, and chloride actually creates this medullary osmotic gradient, the interstitial environment that I talked about earlier, which is high in solutes, and it's maintained by the function of this loop of Henle. We have a very important transporter protein here. It's called NKCC2, which is actually responsible for this sodium potassium chloride transporter. It's a transporter molecule, and this is the target for the loop diuretics like Lasix, furosemide. Okay, so as we go forward, the distal tubule and the collecting ducts, now we are at the fine-tuning time. The sodium reabsorption continues, and in this area, this distal tubule is actually aldosterone sensitive. Potassium secretion. Secretion means it goes back into the urine. Potassium goes into the urine, sodium comes back into the blood. This is reabsorption, this is secretion, opposite processes. And hydrogen secretion, we are dumping hydrogen as well, trying to balance the acid-base status. Keep it at a slightly alkalotic state, which is 7.4. The homeostasis works to maintain this pH very tightly regulated. So hydrogen ion needs to be secreted, means goes into the urine with the potassium. Water goes back under the influence of ADH, which is a hormone secreted by the posterior pituitary gland, and its function is to conserve water. Then after the collecting ducts, of course, there is no more processing of the filtrate. It just goes into the different levels and generations of collecting ducts to be dumped as urine. Okay, now before I finish this, I think so many important information you got out of this discussion. I would like to mention this system. It's called the juxtaglomerulus apparatus, and As I mentioned earlier, the kidneys or the renal system has two functions. One function is excretory, and this is the function everybody knows about. Okay? We spoke about some of the details of how this function is performed. But there is another function that's endocrine function. The kidney is actually an endocrine organ that produces certain hormones. One of these hormones is renin, and renin is produced by an apparatus called the juxtaglomerulus apparatus. Juxta means close to or adjacent to. Look at this. This is the distal tubule, okay? And this is, of course, a cartoonish rendering of the system, just for explanatory purposes. As I said, when the distal convoluted tubule is in its way to join the collecting ducts, it actually goes very close back to the renal corpuscle. This is the renal corpuscle, with the afferent arteriole coming in, glomerulus in, and out comes the efferent arteriole. The distal convoluted tubule comes very close to these two arteries, and actually together, part of this afferent and efferent arteries, and in between there is these cells, floating cells here, and cells within the distal tubule are called macula densa. Remember, within the lumen of this distal tubule, we have the filtrate, the modified filtrate. The filtrate in its final steps of modification, because still some modification happens as it goes into the distal tubules and the collecting ducts. Water conservation, losing some electrolytes or secreting some electrolytes like potassium and hydrogen and stuff like that. So here, when it comes to in contact with these macula densa cells, layer of cells, these are actually sensors. They sense the rate of delivery of sodium chloride through these tubules. And these macula densa cells communicate with these floating cells here. These are called mesangial, interstitial mesangial cells. And these cells communicate with these cells here in their vicinity in the afferent and efferent arteries. And they tell them in a paracrine fashion of communication that to secrete renin. Renin is secreted by these granular cells here. They are called granular juxtaglomerular cells. Granular cells, to tell them secrete renin or stop secreting renin. It depends on what the sensory input from the macula densa is. So, macula densa cells sense the structure, the composition of the filtrate as it goes through, and the rate actually of it passing, and it tells these mesangial cells here to talk to the luminous cells of the afferent and efferent arterioles and tell them to either increase renin production, because they are granular cells. Granular means it has granules that contain renin. Okay, so they tell them to secrete renin or to stop secreting renin. Secreting renin actually activates a system, very important system called RAS, renin angiotensin aldosterone system. And as we go forward in the renal studies, you will find out that this is one of the most important functions of the kidney, because this system is involved with water conservation, solute conservation, sodium and potassium, both are included here, and blood pressure control. Okay, and a lot of newer or pre-existing medications actually target this system. These include ACE inhibitors, angiotensin receptor blockers. There are newer cardiac medications like Entresto, which is a combination of two medications, an ARB and another nitric or another medication. It's used in systolic congestive heart failure. Even aldactone, spironolactone, and its family target this system. And it's very beneficial for the heart and the kidneys, as we will come to know, to actually modulate the function of this system, mostly suppress it down. Okay, so it's very important to know about this juxtaglomerular apparatus and its relationship to RAS. Erythropoietin, this is another product, another hormone that actually works on the bone marrow to stimulate RBC's production. And it's used extensively in cases of anemia, and especially we have it, of course, synthesized. We have a synthetic form that we use in renal failure patients, and renal failure patients has very low erythropoietin production, and that can explain part of the anemia that they have. Okay, the most or the third endocrine product, which is 1-alpha hydroxylase. This is actually an enzyme that produces a hormone, not a hormone. The enzyme 1-alpha hydroxylase acts on 25-hydroxyvitamin D, okay, and activates it to bihydroxy, 125-bihydroxyvitamin D, which is the active form, okay, of vitamin D. And this is very important hormone or hormone-like substance that works or participates in calcium homeostasis, as we will come to know. So please remember, there is the function, the excretory function, and there is this hormonal function of the kidney. Now, please, the things that I want you to take away of this episode is structure of the kidney informs its function. And we saw that in the nephron. Okay, the unique parts about the nephron, or the unique structures of the nephron, actually what allows it to perform its function. Pathology correlates with, for example, understanding the nephron physiology is crucial for diagnosing conditions like diabetic nephropathy, nephrotic syndrome, like in cases of podocyte dysfunction, and we have been through what podocytes are and what they do. And for example, Bartter syndrome. By the way, Bartter syndrome is a hereditary or a genetic problem that actually result of the transporter. The transporter we talked about, NKCC2 transporter, that's targeted by loop diuretics. This transporter is malfunctioning or dysfunctioning in Bartter syndrome. So Bartter syndrome patients actually act as if they are given chronic loop diuretics inappropriately because they don't need it, of course. But that transporter is genetically abnormal in these patients. So these are nuggets here and there just to remember what we are talking about. Okay, and remember that a lot of these areas are actually targets for medications, and the kidney is the way to get rid of medications and toxins and other things. It's the major excretory organ or system in the body. Okay, I hope this is helpful, and please tell me what kind of subjects that you are having trouble with, and I can present them. For now, I will we'll have multiple episodes talking about the renal system. And next time I will talk about chronic kidney disease. And what we looked at here in this episode actually will help understanding the concept of chronic kidney diseases. Appreciate it. Thank you. Please, if you like this video, share it with your friends and subscribe to the channel so that I can feel motivated to do more and more of this. Thank you.